Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 471 of our pharmacotherapy series, which majors in adult hematologic malignancies. The next case reads, TMC is a 61-year-old male in generally good health, who is presenting with a 3-month history of painless axillary lymphadenopathy that seems to come and go. He is otherwise asymptomatic. An excisional biopsy and pathologic examination revealed follicular B-cell lymphoma, a type of indolent lymphoma. ACT scans showed axillary, mediastinal, and iliac lymphadenopathy. Laboratory values are normal. What is the goal of therapy for TMC? Follicular lymphoma, abbreviated as FL, is the second most common form of non-Hodgkin lymphoma and comprises approximately 70% of all indolent lymphomas. The condition predominantly appears in patients over 50 years of age, though pediatric variants have been described. A reasonable percentage of patients will survive a decade or longer with disease. The Follicular Lymphoma International Prognostic Index, abbreviated as FLIPI, identifies age older than 60 years, elevated LDH, stage 3 or 4 disease, hemoglobin less than 12 grams per deciliter, and more than 4 involved nodes as adverse indicators. Initial therapy myriad treatment options are available for follicular lymphoma, though no absolute standard of care has been established. For a small subset of patients presenting with early disease, treatment may consist of radiation therapy alone, which is potentially curative in rare instances. Under most circumstances, however, initial treatment of follicular lymphoma involves chemoimmunotherapy. Similar to B-cell-related aggressive non-Hodgkin lymphoma, the availability of rituximab has dramatically shaped therapy for follicular lymphoma in the modern era. Preferred initial treatment regimens are bendamustine plus rituximab, rituximab cyclophosphamide, doxorubicin, vincristine, and prednisone, or RCVP, and abbreviation for rituximab, cyclophosphamide, vincristine, prednisone. Bendamustine, an alkylating agent with additional properties similar to purine analogues, in combination with rituximab is perhaps the most commonly applied regimen for follicular lymphoma today. In comparison with alternatives such as rituximab cyclophosphamide, doxorubicin, vincristine, and prednisone, bendamustine plus rituximab provides improved progression-free survival and has a lower incidence of myelosuppression, infections, and alopecia. Although bendamustine plus rituximab is currently favored by many practitioners, rituximab cyclophosphamide, doxorubicin, vincristine, and prednisone is supported by extensive experience and remains a reasonable therapy, particularly for patients with advanced presentations. For patients unable to tolerate anthracyclines, rituximab, cyclophosphamide, vincristine, prednisone has favorable tolerability compared to rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone, but compromised efficacy secondary to the removal of doxorubicin. Single-agent rituximab elicits significant response rates with minimal toxicity and is an ideal treatment for patients unable to tolerate the rigors of cytotoxic therapy. Administration of maintenance rituximab in various schedules following completion of initial therapy shows an increase in progression-free survival. My next question to you reads: when should treatment be initiated for TMC? Distinct from aggressive lymphoma therapy, active treatment of follicular lymphoma can be withheld until the development of disease-related symptoms without compromising outcomes. Advantages to the watchful waiting approach include cost avoidance, minimizing treatment complications, and theoretically limiting future drug resistance. Localized symptoms due to nodal disease, compromised organ function secondary to lymphoma infiltration, B symptoms, cytopenias from bone marrow involvement, or an aggressive tempo are generally considered indications to initiate therapy. Because his disease is presently asymptomatic, a watchful waiting approach is reasonable for TMC. Once criteria for treatment are met, therapy can be initiated with the goal being to reduce disease-related symptoms and to prolong survival. TMC eventually requires treatment for his follicular lymphoma and maintains a durable remission after therapy with the bendamustine and rituximab regimen. 3 years later, he has a rapid onset of recurrent disease in multiple nodal regions accompanied by unintentional weight loss and night sweats. Laboratory evaluation reveals thrombocytopenia and neutropenia. Given the characteristics of his relapse, what additional diagnostic tests must be considered prior to providing therapy for TMC? Nearly 1 in 3 follicular lymphomas will transform into an aggressive lymphoma at the time of relapse. In the event of aggressive presentation, a repeat biopsy is required to determine conversion to alternate histology. If transformation is documented, treatment must be intensified to a protocol consistent with aggressive lymphoma therapy. My last question to you reads: what treatment options are available for TMC? For simple relapses of follicular lymphoma, rituximab maintains a pivotal role in relapsed disease and is effective both as a single agent or in combination with chemotherapy. Re-challenge with a previously administered regimen is reasonable for patients attaining a durable remission with minimal symptoms. Alternative first-line regimens may also be effectively used in the relapsed setting. Treatment regimens containing bortezomib, mitoxantrone, and fludarabine have additionally demonstrated activity in patients with prior chemotherapy. Hematopoietic stem cell transplant is an important treatment option for young and medically fit patients. The rapid nature of disease relapse in TMC is an important finding and concerning for transformation to a more aggressive lymphoma. A repeat lymph node biopsy is indicated in this case. If disease has not transformed, a regimen such as rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone may be ideal considering his more advanced presentation. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 472.